And good evening, everyone. I am Lauren Gueits, your host of this evening's Airway Health Solutions Conversation Series with our very special guest, Dr. Shereen Lim. And tonight's topic is reviewing her latest and greatest book, Breathe, Sleep, and Thrive, which I love the title, hashtag Breathe, Sleep, Thrive, and understanding how airway health can unlock a child's full potential. So welcome, Dr. Lim. We are thrilled to have you here.
Yeah, great. Thanks very much for having me.
Oh, it's our pleasure. And, I've enjoyed your book so much, and I'm so glad that we have this resource as healthcare professionals now to share this with all of our patients. It's a great baby shower gift. It's really, it's wonderful, wonderful resource. But I do want to give you a formal introduction for those who don't have the pleasure of knowing you. Dr. Shereen Lim is a Perth-based dentist with a postgraduate diploma in dental sleep medicine from the University of Western Australia. She's been involved in the team management of snoring and obstructive sleep apnea for over a decade. Dr. Lim is dedicated to promoting airway health from infancy as an alternative approach to minimize the development of these problems, and is author of the book, Breathe, Sleep, Thrive, Discover How Airway Health Can Unlock Your Child's greater health, learning, and potential. Her work in private practice is restricted to tongue-tie management from infancy to adulthood, early interceptive orthodontics, and myofunctional therapy. So I cannot wait to hear more about your journey. And what a perfect topic for in the United States, it's National Children's Dental Health Month. So what a better way to celebrate than really start from the beginning, right? From the craniofacial respiratory complex development, as Dr. Boyd would say.
Great, yeah. So do you want me to go ahead and start?
You know what, before I'm just going to do that, I'm just going to protect you and me and just do a disclosure in case there are patients listening as well, just to make sure that they know that the following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health providers regarding a medical or dental condition. Okay, that's the boring part, but I'm glad we got that over with. And yes, let's go ahead, and I can't wait to hear from you, and we have a lot of questions as well. So go ahead and kick it off.
Awesome. So I was asked last week to prepare something for 20 minutes, and that's what I'm going to do, and take any questions after. And so today's presentation really is just about highlighting the key things that I'd love to see change in healthcare, and how much we need to pay more attention to airway health. So I'm going to start with a patient, and this is the type of patient, let me just see how it's going to, yeah. So this is the type of patient that really inspires me to want to see change and to help promote more awareness of airway health. Her name is Mel, and she's a 42-year-old lady. And so I did a tongue-tie release on her child, her infant, about 2 years ago. At that time, I had mentioned something about a high and narrow palate and how that could impact breathing. And so she's come back to me to discuss her high arch palate to see if it could be contributing to some of those issues that she has. And so when I speak to her, I hear about all her problems. She has daily migraines. Once a week, they're so debilitating that she can't just function. She has chronic neck tension, and she has to attend chiro once a week. Otherwise, it will completely flare up. She has fibromyalgia, so pain all over her arms and her legs, and TMD. So she's had a history of locked jaw, and she's very conscious of how she chews so that she doesn't affect that jaw joint. And she also has difficulties swallowing. So she will sometimes choke on her food, and we know that it's related to poor eustachian tube function. And so once a year, when she goes for her first dive of the year, she has a lot of trouble when she surfaces up. It takes about an hour for the pain to resolve. She also has symptoms of vertigo with poor balance and dizziness and nasal obstruction. So she simply can't breathe through her nose. And she's been to an ENT surgeon. She's had some turbinate surgery. And really, that's the end of the line for her. She still can't breathe well. She has very disturbed sleep. So on a good night, she'll wake up about 3 to 4 times for that night. But every other night, she could wake 3 to 4 times per hour. And so it's really disturbed. She has a history of depression. It's recently been easier to manage with antidepressants. She says that it's not that she doesn't think life is worth living, but occasionally she will have some feelings of suicidal thoughts just because of all the pain that she's in. And she also has symptoms of reflux for which she is being medicated. So when we look at her, we can actually see that there has been some poor facial development and this really forward head posture and the way that it's impacting her whole body posture, as well as her neck as well. And so it's very despairing for me to see these patients and the problems that they've been suffering with, and to see them not being able to live life fully. And there are so many missed opportunities where we could have actually intervened early on if we know exactly what to look for. And so when we look at this image of her palate, it's very V-shaped, constricted palate. And if you look at the actual palate vault, we can see that it's very deep, very narrow. So this is a narrow nasal passage and constricted tongue space. Now, when she was younger, she has had serial extractions and braces. And so we've really missed that opportunity to develop that poor jaw development, to develop that arch and get things back on track. But we also know that when we have poor structure, it's a reflection of orofacial dysfunction. And so there are many other opportunities when she was younger, starting with breastfeeding difficulties. So she did have poor weight gain and failure to thrive as a baby, and she had reflux-like symptoms and was unable to keep milk and food down for a good 6 months. We also noticed that she has had eczema from infancy, and so this could be the first sign of allergic disease later on and poor nasal breathing. And she's also got allergy to dust mites, itching, sneezing, hay fever, and she had severe teeth grinding as a child. So her parents didn't want her anywhere near them when she was sleeping. And so these are the opportunities that we could have actually intervened early. And no matter what I see in practice, I see a lot of despairing problems from infancy where people can't feed really well, and it creates a lot of stress for parents and really unable to manage with their really upset babies, or the older children that have behavioral or ADHD concerns, which is really not easy for parents to manage as well. It affects the whole family dynamic. But it is these adults that are the most despairing for me. And it's really one of the reasons why I wrote the book, is to be able to help people know that these problems have their developmental origins from infancy. And we need to be aware of that and get them on a better track. And so these are the concepts that I'd like to see to raise more awareness of and to be able to see change in healthcare. So when we look at her, one of the big things is that conventional medicine, it's very focused on managing disease. She's medicated for depression, reflux, she's got all these problems, but yet we don't really look at the importance of healthy sleep as a key pillar of health. As important as food or as important as exercise, we need to have good sleep. And we need to pay close attention to the way that we breathe, because this actually determines how well we are going to be sleeping as well. And so what I want to say is that we also don't need to focus on obstructive sleep apnea being the, healthcare focuses too much on that diagnosis of those numbers. But we need to recognize that there are many precursor forms that occur from that, and problems begin when mouth breathing starts. So we really need to start looking at things and helping people restore airway health from as early as possible, rather than waiting and managing these diseases with medications later on. So when it comes to airway health, I think it's about restoring nasal breathing and making sure that the airway structures are growing well and the airway is functioning well as well. And we need to do that early on in the earliest years of life. And so as important as it is that we've been able to raise more education, that when we have a child with ADHD symptoms, we really need to look for underlying sleep breathing disturbances. I want people to recognize all these other chronic health conditions that adults may be suffering. We need to look at the sleep. And big one is depression. So when we have depression, there's a very strong link between those symptoms and OSA. And for instance, one of the really big PERF studies showed that there was about 41 patients with suicidal thoughts and OSA. And when they had their sleep apnea treated with CPAP, by the end of the few months, none of those patients had those thoughts anymore. So before we medicate people for symptoms like depression, we really need to be looking at sleep. The second thing that I'd like to see is more focus on good jaw development versus straightening teeth. So when we have crooked teeth, for everybody to be able to recognize it is a symptom of poor jaw development. And so when we have poor jaw development, we have narrower nasal passages, reduced tongue space, reduced skeletal support for our upper airway. And so it's more collapsible. And so it's not enough to look at the teeth and think, how can we get straight teeth? And let's delay treatment, take out teeth and put on braces later on. We need to actually develop the jaws well for optimal breathing. And it's important that we do this during childhood to get that jaw structure back on track. But if we can get better nasal breathing and tongue function for a child early on in life, that is going to help their function and their sleep when their brains and their development really needs it the most. The other thing that I think is really important to recognize is that it's not just about the crooked teeth and the airway, but when we have poor jaw development, for instance, the palate being 4 bones, out of 22 of the craniofacial skeleton, we actually have a distortion of the entire craniofacial complex. So there's a paper by Dr. Mike Mew on craniofacial dystrophy, really talking about that crooked teeth, the distortion of the skull, or the way that our faces are growing downward and backwards, or the melting of the human face, is linked to a whole range of symptoms, including TMD, middle ear problems, chronic headaches, and poor breathing. And so all these problems are all interlinked. And so a person may go to someone for their headaches or problems with their ears. We need to recognize that poor jaw development is the underlying problem, and we need to address this as early as possible. The next thing is to focus on optimizing oral functions from infancy versus managing compensations. And so what this really means is that if we recognize that form follows function, it is the orofacial function, or that the way our muscles of the mouth work, that actually stimulates the way that the jaws develop. And because this grows most rapidly in the earliest years of life, with 60% of skeletal development, jaw development being done by age 6, we need to optimize the oral functions. And really important to start with is the tongue function. We need really good tongue tone or tongue palate suction during sucking, swallowing, and breathing. And breastfeeding is really key to help establish those patterns. And so when we have breastfeeding problems, or we really need to address any underlying factors, including tongue tie, or we need to minimize the use of dummies, which are going to interfere with that tongue suction. Or we need to make sure that we're working well. And so breastfeeding problems, we don't want to put people on shields. Let's get everyone to understand the bigger picture that we need these muscles to be working well. When a baby is using a dummy, they're reliant on it. We need to understand what is the underlying problem. Could it be reflux-like symptoms? When a child has reflux-like symptoms, we need to make sure that they're not sucking and swallowing air, because a lot of babies with those symptoms are placed on reflux meds, different bottles or colic mixtures. But one of the common overlooked issues is the swallowing of air related to poor swallowing and sucking. And this could actually be related to tongue tie. So we really need to start looking deeper at the actual problem. Then when children have prolonged speech therapy, when they're in speech therapy for 3 years, we really need to make sure that we're looking at, do they have enough tongue space, or is their tongue working well? Because when the muscles don't work well and the tongue doesn't develop better tone, we're going to be getting more problems with their sleep and breathing. And when we have problems like teeth grinding, we need more and more people to recognize that this is a red flag, that there could be breathing disturbances, and we need to rule those out. Fourthly, we need to focus on restoring airway structure and airway function versus Band-Aids or one-size-fits-all solutions. So a lot of the time when we have sleep apnea, the solutions are CPAP, dental device, or adenoids and tonsils removing. But it's not really a one-size-fits-all solution. What we need to do, or what our end goal should be, is to develop the airway structure and the jaws and the muscles and re-establish nasal breathing, or else we're going to have relapse. So for instance, with Mel, she has already been to 2 consults with 2 different maxillofacial surgeons, and they have both discussed MMA surgery or double jaw advancement as the solution for her issues. However, if we look at that narrow palate, we can see that that is a root cause of her nasal obstruction. So MMA, although it's promoted as one of the most effective sleep surgeries, that's because it's a multi-level surgery. It addresses the back of the soft palate and the base of the tongue area and the lateral wall collapse. We need to recognize we also need nasal breathing. And to do that, maxillary expansion is going to be a really key intervention. We also know that people that have had double jaw surgery and have had failure of that to resolve their OSA, there is a paper that shows that that is linked to narrow palate and base of tongue obstruction. So if we really want to focus on getting things to function really well, we need to address the high arch palate, get her more nasal passage, get her more tongue space. And so in terms of children, we really need to focus beyond the adenoids and tonsils in restoring the palate structure and making sure children can breathe through their nose with their lips sealed, with their tongue up. The 5th point is really we need inspiration by integration versus healthcare silos. We really need to be working really well together. For instance, we know that if this is a multifactorial problem, that one solution is not going to fix the problem. So we need good collaboration by ENTs in maxillofacial surgeons and all the speech pathologists, myofunctional therapists, our orthodontic professionals. But we also need to start being able to connect the dots between the problems that we see in childhood and how they actually play out into adulthood. I also think that it's really important that we help more parents understand this and that we can even promote education throughout the schools and making sure that all our child health care professionals are really well trained to identify these myofunctional disorders and trained to identify or screen for sleep breathing disturbances, so that way we can help promote airway health for as many people as possible. So now I'm just going to give you a little bit of a summary as to what it is that we really need to focus on the most, because even though we know, for instance, with Mel, she's now had her TADS placed to have palate expansion, we can kind of restore that structure and that function eventually. It is a very complex procedure. We have also done is we've missed that opportunity for her to have decades worth of a better life. What we really need to be doing is promoting airway health from infancy. So good nasal breathing and good jaw structure and orofacial function. So from the very beginning, promoting the mechanical benefits of breastfeeding. It really is the way to stimulate all the muscles, nature's palate expander, and really helps to coordinate suck, swallow, and breathing. Because the moment we introduce the bottle is when mouth breathing will begin. Babies can't coordinate that at the same time. We need to rule out tongue tie when there are latching issues or problems with reflux-like symptoms. We need to minimize pacifier use, promote good chewing, measures to reduce allergic rhinitis and congestion, have screening of sleep disordered breathing for all children, and recognizing that we need to restore airway structure and function through early interceptive orthodontics and myofunctional therapy. So this is a picture of Mel's son, who we saw a couple of years ago. And when I was preparing this presentation, I decided to look back to see what were some of the symptoms that he was suffering. And I actually recognized that they were very similar to what she had experienced as a young child. And so he was having struggles with keeping food down and also being quite unsettled, and also really poor latching. He was creating a lot of nipple damage and soreness, and they were using a shield. And so through the tongue tie release, those reflux-like symptoms were able to be resolved within the week. And then not much longer, they were able to feed comfortably without the use of the nipple shield. And so what's really gratifying to be able to have this opportunity to work with infants is not only can we help to alleviate that current problem, but we can save a lot of anguish for parents, and we can help them feel more confident in their ability to parent, as well as be able to enjoy their child more. Now we have the opportunity to identify what are the next milestones and how can we get things more and more on track. And so I feel fairly confident that as he grows, we are getting him away from the trajectory that his mum has had and setting him up for a better foundation for good lifetime health. And so in summary, I'll leave you with this slide, which is to outline what I think the problems with conventional healthcare is and what is the future. And so I'm happy to take any questions. Thanks for listening.
Okay, well, let me just get my video on. Wonderful. Thank you so much. And this is so helpful because we archive all of our presentations. So I know we have a lot of my functional therapists with us. We have, a myriad. In fact, we could take a quick poll and see the healthcare professionals that we have with us. I'm limited with my choices, so I apologize if your healthcare profession is not listed, but I know this is mostly dental, but let's see with the other healthcare professionals. You can kind of see who we have tonight. So thank you all for coming. And yes, this is a collaborative effort, and we really appreciate you bringing the subject to light in such a digestible way. And if I just may quote you from your book, I loved your introduction. When you really want to empower the parents, you said, quote, "I hope this book will help you find more answers for your child. I hope it will empower you to ask more questions." I love that, to become curious, to seek alternative options and know that the choices you make for your child are informed. So thank you for giving us this tool to help empower parents to make the right informed, educated choices for their children. But I'm going to end it with, I think is so poignant, is that you say, quote, "Mostly, I hope this book provides you with exactly the information you need to lean into the significance of airway health and become part of the movement to change lives, both now and in the future." I mean, what a wonderful world it would be, right? If everyone would just go to the root cause of disease, it would really change healthcare as we know it. So let's get right to the questions. I really, really appreciate your time. I'm going to stop sharing so we can actually see. Why don't you stop the sharing so we can see you up close and personal here. There we go. Okay.
Oh, that's so good. It's been a little while. I've been doing so many podcast interviews and being able to watch people.
Yeah.
It was going back to actually talking to myself was a bit strange.
No, it's not. I didn't want to distract you with my photo there. So here, so we have interaction, and we actually had over 200 people registered. They couldn't make it tonight, knowing they would get the recording, but we have 75 with us tonight. So kudos to everyone for taking time out on a Wednesday evening, probably after a work day. But Dr. Mark Levy, hello from Australia. How do you treat 4 to 10-year-olds? I know that's a very broad question, but maybe you can give us a very concise answer.
Yeah, the idea really is to restore jaw, airway structure and airway function, and ultimately achieve nasal breathing. So whether it is a child or an adult, ideally what we want to do is develop those jaw structures, make sure that, so through orthodontic treatments and also getting the tongue to palate to tongue contact and nasal breathing. So through my functional therapy, addressing any tongue ties. Mm-hmm.
Excellent. What is another option if mom is not able to breastfeed?
Yeah, if mom is not able to breastfeed, we want to make sure that we firstly rule out those, see a lactation consultant, a trained IBCLC. We want to rule out any barriers for them, but if they really can't do it, then we just need to recognize that it does alter the suck and the swallow and the way that the muscles work, and we need to take the next opportunity, which is really going to be about chewing. So how can we get children to chew well? I really like the idea of baby-led weaning and making sure that we can actually get children chewing rather than overdoing the sucking of the purees. And also the BB munchie, I'm a big fan of that for the infant population. to normalize swallowing, to release any overactivity of the lips and cheeks, and just introduce good jaw motion as well.
Great. And can palatal tori cause or contribute to sleep apnea?
I'm not really 100% sure about that, but I do think that when we see those palate tori, yeah, it could be a reflection of some sort of clenching or grinding. Yeah.
Right. And is CPAP machine short-term or is it for long-term use?
Well, for children, it really should only be short-term use until they can get some jaw development, unless they have some sort of syndrome where it makes it difficult to do orthodontic treatment. However, with adults, it can be a good solution if they don't want to progress with extensive jaw surgery.
Province, he's going to be our guest in a couple of weeks telling his airway journey, but he asks, do you see these positive changes in Australian dental care, especially with the children?
Do I see
the collaborative care? Do you see the movement happening in Australia dental care?
Yeah, sorry if I don't respond straight away because I think it cut out a couple of times.
Sure, sorry.
No, not so much. I do feel that the US has got more traction, you know, so I think you guys, as frustrated as it is over there, that some of my colleagues over there feel, you are definitely doing better over there. And people like Dr. Steve Carstensen, they've done such a great job of really helping get this policy statement on the dental professionals' role in screening and managing obstructive sleep apnea or sleep-related breathing disturbances. I think that's so important to have people like him. So he's my hero. One day I'd like to be like him. But yes,
well, he's with us tonight. Actually,
really? I have no idea he's here.
In fact, that's so funny. I can see if he wants to come on and say hello. We can take him off mute if I can figure out how to do that. I don't want to put him on the spot, but I know he's not shy. Let me see if I can, if he wants to come and say hello about the changes. He was on here. Hold on.
Okay.
Let's see if we can find him. But yeah, let's see. He was on earlier. there are a lot of names here, which is great, really great. So Gerald, my assistant, if you can find Dr. Carstensen and allow him, give him the mic, we'd love to hear from him. Okay, let's see. Is it possible for grinding to recur after palatal expansion in children? If so, what would be the underlying cause?
Yeah, you know, I would say that a high proportion of sleep bruxism is going to be related to the airway, and airway is a very multifactorial problem. And so, yes, palate expansion is really good at improving nasal airway and nasal airflow, but we also need to consider that the tongue, low tone tongue, is actually a risk factor for sleep disturbed breathing. So we've got to make sure we address that, as well as any allergies, because some of the children with allergies may need further management to be able to restore their nasal breathing.
Dr. Levy is just saying your toolbox, do you use guides or RMA? Or a combination?
Oh, like my functional training devices?
Yes.
Yes. I am a big fan of palate expansion because it's so impactful. You can get in there within 4 to 6 weeks. Parents will notice improvements in the symptoms. It really makes more tongue space. So if we're going to do myofunctional therapy, we can actually get that space for the tongue to work better. As well as if there is any issue with mouth breathing, I do think that's the quickest way to help improve nasal airflow. So I really like palate expansion. We know the research shows even a few millimeters can exponentially improve the airflow. And we have this one opportunity in childhood to get that extra bone. So I do like that. A lot of patients that I see, I will use that. And I use the guides in combination because for stability of results, we need to get that tongue up, the lips closed, nasal breathing. So the guides I use them more as training devices to get the muscle balance correct rather than to actually get expansion.
You find the right specialist. Not all ENTs, dentists, orthodontists, etc., specialize in airway function. So if you're having a hard time, we're having a hard time here. It sounds like you're having a hard time there as well. Can you give us any tips?
if you're having a hard time to find an ENT specialist to do surgery.
Well, I guess just to collaborate, because not all of them specialize in airway function. So do you have any tips that you use to create your network where you are?
Yeah, for me, I don't think we hugely collaborate in the sense of they refer a lot of patients to me routinely, but I know that I have good surgeons that if there is an airway problem, if I write a letter and I can really list what are the concerns, and if I tell parents just to make sure that they take video of any disturbed sleep or snoring, all those symptoms to help validate their concerns, I think that is really important to get an ENT surgeon on board.
Great. And what age is best to stop using a pacifier?
Well, definitely
It's a trick question.
I think they should be used like soothe and remove.
Yes, I like
so if
that.
a baby is not unsettled, we should really be eliminating it straight away. And then from the age of 6 months during the daytime, we can really use the BB Munchie. That'll introduce more appropriate sensory and functional stimulation. And so I really like that, to try and give a baby what they need so that we can wean them off the pacifier.
So 6 months, you're saying, for the baby Munchie?
Yeah, 5 to 6 months.
Okay, great. Let's see. What age do you start ortho? What's the earliest, let's say?
The earliest is 3.5. So I know people like Dr. Audrey Yoon, they've started from 2-year-olds, and she's a pediatric trained dentist. So it can be done as long as they have all their teeth to anchor the appliance. More and more what I saw was, all these children are sleeping better, functioning better. There is really no need to wait. And it was people like Lauren Ballinger,
yeah.
as well as Kevin Boyd, really saying, when we have children with glasses, with vision problems, we don't wait until they're older and tell them not to get glasses because they're going to need a new set every year as they grow.
Right.
Because what experience are they going to miss out on? And so I thought, that's quite true, because when children don't breathe and sleep well, it's a really important time of development. So what are they missing? So I think for me, it makes sense. If we can get a child on board and compliant, why don't we start early if there is a problem?
Standard of care in Australia for ortho to begin orthodontics?
Yeah, well, I had a mum said that she went to the orthodontist. All the time she's been taking her child to the dentist, and they've been saying, go and see, when your child is 7 to 8 years, we'll send them to an orthodontist and they can actually do palate expansion. So that is the traditional age, generally speaking. However, she went to 2 different orthodontists and they both said to her, don't worry about it. Don't need to worry about it. We can just deal with this later and we can just take teeth out. And I'm still in shock that people can actually say these type of things and it's accepted. However, she didn't. So that's good for parents to understand that.
Right. And it's good for them to have this resource that they can read and understand. You did such a nice job at making it digestible. Is there any research indicating that colic is related to infant airway issues?
Yeah, definitely, more and more. And I actually have a full list of all the research papers that show this. When babies have reflux-like symptoms, it can be related to poor sucking and swallowing and the introduction of air. So a lot of babies, they will have this clicking and you can hear them gulping air. And so a lot of the time when we address the tongue tie, those issues will resolve. And it's really important because a lot of babies, they may get medicated for these symptoms. And we know that the research shows that when we put babies on antacids, they're going to have an increased risk of bone fractures later on in childhood. So that we don't have any evidence to really prove the effectiveness of these reflux-like medications. But yeah, we have quite a number of papers that show when we address the tongue tie that we can get an alleviation of those symptoms. So I think if we want to practice evidence-based treatment, we really need to be not overlooking swallowing of air.
And again, I'm so, with your book, you have so many references listed by the chapter. So that alone is priceless. So you have everything that's easy to digest and to read. And then you have all the references and the science listed per chapter. Great job on helping with that resource. Should all kids that grind be evaluated for airway issues?
Yes, I believe so. There is no harm in asking how is a child's sleep and breathing going,
Yes.
and trying to help them with it. And even when we look at, for instance, a research paper that Audrey Yoon did, 90% of the children that had tooth-related or teeth grinding, they actually had low tongue posture. So they had enlarged tonsils, tongue tie, or mouth breathing. So we really need to address this issue because that could be the underlying problem. And
Yes,
it's
and
not helping the child sleep.
Okay.
Yeah.
Dr. Silberg just commented, thank you for sharing. Maxillary tori occupies room for the tongue, closing in on the lingual spaces. So thank you for sharing that. Dr. Provins would like to know, at what age do you stop RPE and move to TAD-assisted expansion?
Yeah, well, I don't personally do TAD-assisted expansion. And actually, I don't have anyone in our city. We don't really have anyone that really does it. Like Mel is going to one person, but generally speaking, it is actually not that common here. And so for that reason, sometimes when I see someone that is 9 or 10 and I think they're having significant problems, I'll still expand them just traditionally. But I think around the age of 9 is when the palate starts to fuse. And if a child has a very high and narrow palate and they have disturbed sleep and poor daytime function, we really should be looking at those TADs from as early as that age.
For teens, what happens with the mandible when a patient is undergoing palatal expansion? Does it adjust, or does mandibular expansion need to occur simultaneously?
Are we talking about the retrognathic mandible?
And I guess undergoing just palatal expansion, does it adjust, or does mandibular expansion need to occur at the same time? So if you're doing upper and lower palatal expansion, do you do it at the same time?
Yeah, for me, when I do palate expansion, I just want to deal with the palate. And because I'm working in really young children, I think that the palate is a template for normal mandibular development. So often if the palate is narrow, we're going to get this inward tilting of the lower teeth. So if we get in a child young enough, if we can expand the palate, it will allow the uprighting of those teeth. And sometimes when we have that retrognathic mandible, it's because the palate is so narrow or V-shaped. And what that means is like a pointy shoe. It doesn't allow the foot to go in all the way, or in this case, the mandible can't translate forward, it gets trapped. So I think when we get that V-shaped arch and make it more U and we widen the palate, it allows that forward translation of the mandible. And so I think that's quite normal for a younger child, but I think the older and older a child is, it's more difficult to see those changes. But I do tend to work with children that are maybe 8 years and under.
How do you use and do you prescribe a baby munchie?
Nearly every child I feel can benefit from a baby munchie. So I'm really looking at the children that have their open mouth posture, or maybe children that have used a dummy in the past, or drooling babies, drooling being a reflection that there is improper swallowing, the tongue is not lifting and going backwards and the mouth is dropped open, or any of these babies that really like putting things in their mouth. They're all babies that I would try to do that for, and just to get them chewing more and getting things working more. And in terms of how do I introduce it, what I've found is that babies like watching other babies. So I've got a few videos and I'll show them and let them see it. And then I'll let them mouth it a little bit, just to kind of get familiar with it till they're comfortable with it. Once I see they're really into it, I might take it away and then make them want it, and then I'll slip it into their mouth. And so, yeah, that's more or less how I would introduce it, and just ask parents to use it, maybe a minute here, a minute there. And if their baby really likes it and it's seated inside the mouth, just to let them have it as long as they are still interested in it, like longer.
That the babies want it? Do you ever find that they don't want it? Is it more of an
Yes.
instinct to want it?
Yes, there is definitely some babies that will not take to it.
Okay.
In fact, there are some babies, like I had, a baby chuck it on the floor. There are some babies that have character. The moment you look at them, they're gonna like not
That's
participate.
funny.
So I really try to also ask parents to gently hold their hands down sometimes when it's seated inside the mouth, so they're not always pulling it out. But yeah, if they can't get it in on the day, I'll just say, you can do things like on the instructions, it says put applesauce in it, put it in the freezer. Just celebrate even them munching it without putting it in their mouth as a win. Just let them get really comfortable and build into it.
On the same topic, is a baby munchie only used during daytime, or can it be substituted for pacifier at bedtime?
I would probably avoid using it at night. I don't know if it's meant to be used at night, but anything that goes in their mouth could potentially affect their breathing.
What if a client continues to present with sleep disordered breathing characteristics such as grinding and occasional snoring after upper expansion and tongue tie release? I guess this is a specific client. They say client is currently in myotherapy.
Yeah, I haven't really seen it that much, really. Yeah, there could be many other reasons for it.
Right.
There's
I know
also
it's hard to speculate.
Yeah, but definitely ruling out allergies. I mean, that's really another big problem or barrier to the goals of treatment.
Right. And Dr. Harrell, thanks for joining us tonight. As Dr. Guilleminault said, we must establish nasal breathing for success. Do you use or recommend rhinometry to objectively measure nasal resistance and monitoring nasal flow? We have begun using interesting results.
Yeah, no, I haven't done that. And, I really go by the parent symptoms, which are a really big deal, to hear their relief and problems. And this question was asked at the ADA Children's Airway Conference, where Dr. Stanley Liu was one of the speakers as well. And he suggested, well, we have a nasal cycle so that the nasal airflow is different at different types of the day and even during sleep and the position that we sleep in. So it may not be super accurate to use nasal rhinometry depending on when we do it. And he suggested that the NOSE score, validated screening questionnaire on the symptoms of nasal obstruction, could be more important for research-based purposes. But yeah, I think, it's good. I'm really open to learning from Dr. Harrell and anyone else that's doing it.
Right.
Yeah, I think it's really interesting. The more data we have, the more people will listen. So yeah, I'm really open to listening to it, but not me.
Yeah.
I haven't done it so far. Yeah.
Dr. Brett Christensen has a lot of data on that we have an archived conversation with him that you may want to check out. It's very, very interesting. So about tongue tie, who is your favorite technique or mentor?
Oh, well, with tongue tie, the first person that I learned from was Dr. Larry Kotlow, and really to understand what are the problems, how to assess, Dr. Kotlow was really my person that I did for infants. And in terms of older children and adults, it would be Dr. Zaghi. It was a real game changer to do his course because really understanding the myofunctional therapy, the key distinction that I got from that course was when we do the myofunctional therapy to watch out for compensations, to watch out for the neck or jaw muscles working, to really focus on tongue isolation. So that was the best course for sure, and really has influenced the way that we do things. And really for the adult patients that have chronic head and neck tension and those type of problems, yeah, big game changer.
I also want to know this. So will you be recording your book for an audio version? You have such a lovely speaking voice.
I've had so many people come and say, I bought your book, but I haven't read it yet, which is quite funny to hear.
Right. Yes.
So, it is on the cards, but right now, one of my goals is to do a podcast. Someone has suggested do a podcast. I've always wanted to do a podcast, interviewing different guests and really bring more information to the forefront. But someone said, why don't you start with a very quick 20-minute, one chapter per podcasts, just really digestible for parents. And so that's going to be my first goal, as opposed to the
keep us posted so I can share for
Yeah.
sure.
Yeah.
When you are evaluating for palatal expansion, are you looking for a certain measurement or palatal shape?
Yeah, okay. So when I'm looking for palate expansion, what I want to do is I want to imagine what would I want the palate to look like if the bottom teeth were upright. And then I'm actually looking at the tongue to palate suction and seeing how much spillage or how well does that palate fit, the tongue fit in that palate. And they'll be my measures, because I think the measurement will vary for different people.
Great. There were a couple of questions that were asked that when people registered is, what is the earliest age you can start correcting mouth breathing?
Yeah, from infancy.
Yeah.
Even my, I did a tongue tie release on one of my team members' child yesterday, and she said, oh, she noticed her daughter was like, always had the mouth open, but then she straight away lifted it up. And the baby doesn't do that anymore. And so we got to recognize that if the baby always has their mouth open, they will become a mouth breather. So those type of things are really important.
Okay, and let's see. Do oxygen levels increase by holding the breath when doing breathing exercises?
I'm gonna pass on this question. I don't feel
okay, no problem.
Yeah.
I just wanted to say, let me see. I think you covered a lot of this, but what are tips for parents to use to help children how to breathe, sleep, and thrive besides reading your book?
Yeah, I want to say to read the book.
Yes.
Definitely to recognize that there are many opportunities from birth. And to recognize what are those milestones: breastfeeding, nasal breathing, avoiding dummies, all those things listed on that Airway Health from infancy slide. And really, I think what is really important, and I think one of the really significant interventions that we must not overlook, is palate expansion to address that high and narrow arch. Because sometimes I'll see the infants and we do tongue tie release to help their breathing, and we can kind of just see that there's a really high and narrow arch. And actually, I know these are the children that will be mouth breathers, increased risk of ear infections, and probably adenoids and tonsillectomy. But to recognize and help those parents understand that you want to address that high and narrow arch as early as possible. It's super impactful to allow the tongue to function better, as well as promote nasal breathing.
Okay, well, I'm sorry, I didn't mean to interrupt. And another thing you have to share?
I just think also we want parents to know that when they have an ENT surgery, like adenoids and tonsils or grommets, make sure you consult a dentist and myofunctional therapist as well. I think that's really important.
Oh, that was a question I wanted to ask you. What is your philosophy on myofunctional therapy?
I think when we have problems with sleep and we have problems with jaw development, we need to address the root cause. So it has it has such a big role in doing that, because all our interventions, whether it is palate expansion or whether it is surgery, it will relapse. Those results will relapse if we don't actually restore the proper muscle tone, tongue posture, and nasal breathing.
A therapist in your office?
Yes, I have a couple of people that do it.
Wonderful, wonderful. Well, I'm just going to provide some updates on what's coming up, what's new. So I hope you can join us for that. It's going to be about 5 minutes. I just want to share with everyone upcoming events. And then we'll circle back and just kind of close out. But we do have our mini residency with Dr. Ben Moralia on adult expansion, which is removable expansion, as well as clear aligner therapy. There's a couple of spots open for Friday, and here are the rest of our dates. And we'll be sending up follow-up emails, so don't feel compelled to write anything down. I'm really excited about this course, March 3rd and March 4th. It's 100% virtual, where you'll learn Dr. Moralia's fixed expansion techniques for older children, and also his expansive bracket and wire techniques as well. So join us for that March 3rd and 4th. It's really a great follow-up if you've taken the pediatric mini residency. So it is an advanced level course. We love Dr. Gelb's TMD to ortho. It's basically the prequel to ortho, to airway and orthodontics. That's 100% virtual, March 31st as well. And we're so excited to have Dr. Brett Christensen. If you have orthodontists, Dr. Harrell, I know you're on board, but there are a lot of orthodontists who aren't familiar with airway orthodontics. It's not part of the curriculum. So if we can get more orthodontists on board, that would be wonderful. And we have a peer-to-peer course to do so. That's going to be a pediatric one day, May 5th, Cinco de Mayo. And we just finished Dr. Boyd's advanced mini residency a couple of weeks ago. We're having our next one October 6th and 7th by popular demand. And he's the same philosophy as you, Dr. Lim. I know you mentioned him and his techniques in your book as well. So he treats also 2.5. And this is an advanced course showing you how to do expansion under the age of 6. So like you've mentioned, he thinks above 7 is basically the geriatric patient for Dr. Boyd. So it's really a specific course with specific techniques. And because Dr. Boyd is so adamant about myofunctional therapy, like Dr. Lim, he really wanted to see myofunctional therapy course focusing under age 6. So we're really excited to present this. Carice Laguerre and Brittany Sierra Murphy are our instructors, and it's going to be basically therapy, treatment planning, and screening for kiddos 18 months to 5 years old. So it's a really specific course that I think you'll get a lot of use out of if you're treating the specific age group. So join us for that. And all our myofunctional therapists who are on board, we do have a 6-week private practice myo. It's starting February 15th. And then we have our mini myo course, as I said, that's going to be March 24th, and our 2-day practice integration course. So what this is for is really to practice myofunctional therapy in the dental office. It's really a niche course to learn how to do that. So maybe you don't want to open up your own practice, but you want to incorporate it in your dental practice. Dentists may not want to refer out and keep the compliance factor high by having it in office. This is the solution for you. So please visit our website. We have our airway dentist locator. I'm constantly asked, where can I find an airway dentist? So we actually have many more dots because we did have someone in North Dakota a couple of weeks ago. So we're filling up the middle of the country a little bit and a little bit more in Canada. So if you're looking for an airway dentist, follow this link and you can look for a dentist near you who has an airway centric philosophy. Dr. Lim, I have to add you to our list here, so I'm going to have you fill out our survey so we can get you on our international locator. But we're really excited to have a global presence. And again, it's the Airway Health movement, and we need everyone on board to do so. Here's Kevin Ohlendorf's contact lab contact. I know that Dr. Moralia uses all of his appliances as well as Dr. Boyd. Our Airway Dentist Facebook group, it's a private group for our doctors who were trained. So if you're on here, I see a lot of alumni and you haven't joined us, please do. It's very active. We have case reviews in a very safe place, and it's a very supportive group. So you can ask all your questions and have that community support. And then we have our public Airway Health Meetup group for healthcare professionals. So I invite everyone here to join us. We constantly give new information. I share a lot of your information, Dr. Lim, so thank you for always providing such wonderful cases and information on your Facebook group. Dr. Moralia will be presenting at the Hinman meeting March 16th and 18th. He's presenting Thursday, Friday, and Saturday. This is really a lot of where people got their aha moments. Dr. Lauren Ballinger actually attended the Hinman. That's when she first got kind of turned on to airway from attending a course like this with Dr. Moralia. So it's amazing what you can do by just opening your eyes and ears and learning new things. So this is a great opportunity. Also refer your colleagues if they're going to Hinman to see Dr. Moralia. And the good news is that the courses Friday and Saturday are actually free, as in free. So that's always nice. And I'm just going to help promote Dr. Gerald Simmons. His dental sleep conference is in Houston, April 27th and 29th. Dr. Boyd will be presenting as well. It's a multidisciplinary conference, so this is a great time to really learn and talk to all the experts. I'm crossing my fingers that I'll be there as well. So we do have a discount through AHS. That'll be in your follow-up email. And I'm thrilled for our faculty member, Carice Laguerre. She's hosting the first Dental Culture Con in June 15th to 17th in Atlanta, Georgia. She's being the change she wants to see. And this is a wonderful, wonderful time. We're celebrating Black History Month this month, but she really wants to bring dental diversity to the forefront. And this is great for corporations, for dental offices, for clinicians, really just come together and celebrate the different cultures. So we're going to have a Facebook Live with Carice on Saturday to learn more about that and to celebrate Black History Month. Airway Palooza, Dr. Lim, if you could join us, it's going to be March 2024. I'm still securing a venue and an exact date, but I'll give you as much advance notice as possible. We would love to have you there. It was such a success in December, and we really, really had a wonderful time pushing that Airway Health movement forward. Our next conversation series is Dr. Scott Province. I'm so excited for him to share his heartfelt story from just general dentist now to airway dentist. So I'll let him tell his story. We have Dr. Reza Movahed coming up March 1st to share some of the MMA case reviews. It's always so fascinating to see it, firsthand. And then I'm so excited to have Dr. Jivanan, I hope I don't mess his name up, Jahandran. He said, call him Dr. JJ. So that's what I'm doing. And he's with us tonight. So I apologize for butchering the name. But what I'm so excited about is the integration, the key to upper airway health. He's an ENT. So he's going to have a lot of those missing pieces and those questions answered that we had tonight from an ENT standpoint. We also have Collaboration Cure, save the date, September 7th through the 10th at Orlando, Florida. We're a proud sponsor of that. And all of your airway mentors will be there. So hopefully everyone can come and celebrate the collaboration and come together for the airway health movement. Well, the good news is that I had a lot to share, which means that we have a lot going on in the United States. So Dr. Lim, I thank you so much for your time and for your passion and dedication for airway health and being such an important driver of the airway health movement. Was there any closing remarks you want to say or words of advice for someone who may be just, dabbling or interested in getting started?
Yeah, well, obviously it's really important to learn more, but in closing, what I'd rather say is thank you for all the work that you're doing, because there is so much interest from parents nowadays, and they are struggling to find providers, and it's really not fair for people to have to travel or fly in and fly out. And so you're really a big part of the solution in terms of educating dentists. And I'm so excited that you are able to get another course on for the year and have more and more people involved in that. And what I'd like to say as well is, if there are people that are doing primary dentition orthodontics, I'd love to hear from you just to even find out a little bit about where you're located, because every day I just get a batch of people that want to know who can I go to. So it's always nice for me to know who else is out there. But yeah, thanks so much for the opportunity and all you do.
Thank you. And what's the name of your Facebook group so everyone knows? It's Airway Health for Children?
Yeah, Airway Health for Kids. It's letter 4, and that's where I try to promote a lot of new research so that we can really understand why we need to pay attention to this.
We'll include that in the follow-up email as well. So it's a collaborative effort. Thank you everyone for being here. We can't do it without you. So thank you everyone.
Thank you also for everyone to take the time to actually join live. It means a lot. Thank you.
Enjoy your day. Thanks everyone.
Take care.
Good night.
Bye.